Evaluation of patient with low back pain and operative perspective. And so I don't have any disclosures. Now, Ron Bergman was an assistant professor of ethics and philosophy in the Netherlands. And he went to his general practitioner with low back pain. And he kept returning to her only to be told, that nothing's wrong with you and, you can't see a specialist and, he gets a diagnosis of functional, non-specific low back pain from work stress. And his back pain was in fact due to non-Hodgkin's lymphoma. And before he died, he actually published a series of articles in the British Medical Journal on the dangers of jumping to conclusions when making a medical diagnosis. And he said the reason why the diagnosis was missed was because his primary care doctor had confirmation bias, where she could only find what she assumed to be wrong. And so this is a recent paper on nonspecific low back pain, and it gives this frequently quoted statistic that 80 to 90% of low back pain is nonspecific and short-lived, and that imaging's not recommended, and there's no labs, and if it's really chronic, then you just recommend exercise and behavioral therapy. But there's a disconnect between all the spine practices I've ever been in and what this paper says, because we don't think that 80 to 90% of low back pain is somehow without an identifiable cause, and we don't see that. And so the diagnosis of nonspecific low back pain is in fact nonspecific. And there is a logical fallacy here in that they want to define it as nonspecific low back pain that assumes nothing else is wrong, and therefore you're not doing any imaging.